So hi everyone, today we're going to talk about gender equality in humanitarian health and nutrition response. That's officially our first distance learning session, and Catherine Hingley was very kind to develop this session especially tailored for you guys. Catherine is a gender and gender-based violence humanitarian advisor at SCUK, and she will be leading you through this webinar for the next hour or so. Stay with us if you've got any question. You know you can use the chat box and we'll pick those questions on the way. And at the end of the webinar, Alice will have a few words regarding the next steps of the diploma. So Catherine, over to you now.
The expected learning outcomes are 3, although it's just an introductory session, so we will not have as much. We'll have more exercises to follow up so that we can become more familiar with guidelines and with tools. But really what we want to do right now is explore together how gender inequality and harmful gender norms affect public health outcomes, and understand what our mandate is as humanitarians to work on gender, why it's really important to our work, and then, as I said, become familiar with guidelines and tools. So the first part of that is around what is gender. So some of you may know and be very familiar with it, but it's really worth exploring what does this mean for us? How might this have affected our lives as well? And then how is that going to affect humanitarian public health outcomes? So we had this think back to your childhood. If anyone who didn't share wants to talk about it a little bit more, please do. But what I had heard from the chat was a few things along the lines of girls didn't want to wear skirts to school. They'd rather play, they wanted to play football, but were told no, volleyball is better for you as a girl. When drawing the family tree, it only really had men on the family tree, and also Hama is in a twin with a boy, and she wanted to play with friends, but I believe there's some kind of restriction related to that. And then quite a few related to being separated out at level 5 in elementary school around age 9 or 10. Does anyone want to add anything further? I can summarize a little bit related to how these differences are reinforced and what it often means for boys and girls. Okay, so I hope some of you heard already, but as I said earlier, basically we treat boys and girls differently. It doesn't matter where we're from, whether it's from Western Europe or from the Middle East or from Southern Africa. There are differences in the way that parents, in the way that teachers in society and individuals will treat each other, and these are based on social expectations of what your role is, how you should behave and things like this, and that actually affects both boys and girls. And it also affects the way that they grow up. It affects how confident they are, it affects their skills, educational level, it affects what kind of resources they might have access to. So the point about the family tree was quite interesting if it only has men on it, because that's the lineage, and therefore inheritance will go through that family line. And that also relates to accessing resources, whether or not you're invested in for education, what kind of job you then get, how you make decisions. It relates to whether you're independent or dependent in many ways. So this is really crucial, and often when we think about gender, many times we conflate it either with being, okay, gender means women and girls, or gender is a biological sex. It's basically around, okay, I'm born male or female, and therefore this, our social kind of role and how we behave is absolutely determined on the basis of biology. What I was saying also there was, of course, biology does play a role. Like, it's clear males and females especially in the context of healthcare. They're exposed to different diseases, but also maternal healthcare is for women because that's biological characteristics that males are not able to give birth. So clear. But it doesn't also mean automatically that females then take on all the burden of care around looking after children and other family dependents, or males are the ones solely responsible for bringing in the income, though that is often the case in traditional societies and continues in most contexts. So what's important to note when we're talking about biological sex is that that actually doesn't necessarily determine what our social role is, although we often expect that it does. So gender is actually the term used to explain this social construction of roles, behaviours and attributes that society, whether it's our peers, whether it's our parents, whether it's anyone else we come into contact with, that they consider appropriate for males and females. Now, we often think of males and females being very binary, and I mentioned earlier, and it's on the slide, the box related to sex, is there's actually a diversity within this biological sex. So there's up to 2% of the population is born intersex, where there's a diversity either in their a genetic diversity, then their chromosomes, their genitalia, and so on. So this is quite important. And then gender along the same lines is also considered to be quite binary, and those that don't fall within the expected behaviours of either male or female are often excluded. But some of the key things that I was mentioning earlier were along the lines of men and boys there tends to be this expectation that they are the primary breadwinner within the family. They're invested in terms of education. It means they often have higher literacy levels. They also have the family lineage, therefore they have more access to resources within the household and they're expected to be the main decision maker. They're also expected to be the main protector of the household. And one of the things that we often forget is this kind of social pressure that's there for them to perform that role. The same is also true for women and girls, but they are expected to have a different role in terms of, largely reproductive role actually, in terms of giving birth to children, looking after children and other dependents, and being very much actually the domestic support within the household. So the spheres of influence or where they're involved, like women and girls tend to be much more within the household space, especially in very traditional setups, and men and boys tend to be much more kind of decision makers in the household, but then also outside in the community and the community level as well. Okay. One thing that I did make a key point to was that gender actually changes significantly across different societies. Also within the same society, it can depend on which generation you are. It can depend on your geographical location, your educational level, income, things like this. So gender actually changes over time, over space, between different societies. It's not fixed, whereas sex certainly is a biological characteristic, and without surgical intervention doesn't change in general. Okay. Some other key terms that are really important and that we'll be coming to throughout this session are around gender equality. So this actually means the absence of discrimination on the basis of sex or socially ascribed gender norms and roles, resulting in equal rights, resources and opportunities. So the absence of equality, actually, where there is discrimination on the basis of sex, is of course gender inequality, and that's the current state that we're generally in at the moment, where boys and girls, men and women, don't have the same level of decision making, access to resources, ability to to make decisions and access services that we might be providing in a health and nutrition setting. And actually there's some arrows between gender-based violence, or GBV as it's abbreviated, and gender inequalities, whereby where there is gender inequality, gender-based violence is more likely to be perpetuated. So gender inequality reinforces violence on the basis of gender. So and vice versa, basically. So as I mentioned, in terms of these kind of very traditional or binary gender roles between males and females, gender-based violence can be used as a way of reinforcing these roles and these power hierarchies. And in reality, actually, gender inequality is about a power imbalance, which is socially constructed. Another key point, which is often hard to visualize, is about how discrimination can kind of overlap depending on what your gender is, what language you speak, whether you have a disability, where you actually live, so your geographical location, your ethnicity, your sexuality. And so often what we find is people have sort of double or triple discrimination. So you may be female, have a disability, and be from a geographically isolated or poor area, and therefore have much more difficulty to access services than if you're female and say from a higher caste or majority ethnic group that has much more linkages and access to services. So these kind of, the interplay is very crucial. So when we're talking about gender, we're not saying that all men and women are the same. Actually, they're not at all. So it's a really crucial kind of point to make. Okay, so in terms of our humanitarian objectives, these are kind of general cluster kind of what do we do in humanitarian health response? Well, the main aim is about the reduction of excess morbidity and mortality, of course, specifically around children under 5 and vulnerable populations affected by crisis. And then nutrition is the same around this reduction of morbidity and mortality caused by acute malnutrition, and particularly, of course, the children under 5 and pregnant and lactating women. And I just wanted to kind of keep those two in mind while we go through the rest of this session, because some of the statistics that, these global statistics that I'll show you here, also kind of relate to how does this affect those two outcomes for health and nutrition in humanitarian crisis. So this is one global statistic around how gender inequality affects boys, girls, women and men. Sorry, am I seeing something? Okay, so as you can read from the slide, so girls, and I think many of you already know this as health and nutrition experts, is that of course girls who give birth before the age of 15 are much more likely to die in childbirth than those who give birth when they're over 20. And of course the corresponding infant deaths born to mothers under 20 years of age. So this also links with the a lot of the time in humanitarian contexts where there's, and in cultures where there's, where it's socially acceptable for girls to get married at a young age, particularly early when they have their menses, or when there's a lot of pressure within the household, and therefore early marriage seems like a good prospect. So of course this is then impacting our response in terms of health and nutrition of those girls, and of course the infants born to them. Okay, so then this one is around family poverty, and it's an interesting one. You'll see that these statistics aren't from humanitarian context, but of course the underlying issues are going to then affect a crisis situation. So this one shows that this 1% fall in GDP increases infant mortality, but there's a difference between the between this infant mortality for both boys and girls. So it's actually 7.5 deaths per 1,000 births for girls, where opposed to 1.5 deaths per 1,000 births for boys. Okay, hang on. So GDP, sorry, gross domestic product. So it's around rates the economy. So basically, where there's a decrease it's around poverty rates basically increasing deaths, of course, but then it specifically has a differential impact between boys and girls. This is globally, so it masks kind of regional and country and even community level differences, but it's indicative really of where of often kind of preferential feeding practices between boys and girls. So where there's a kind of, okay, a boy is more valuable because he's going to inherit our family name, he's going to inherit our property, we're going to invest in him, so we'll feed the boy more than the girl potentially. So there's a lot of, and that's certainly the case in Asian countries that I've worked in, for example India and in Nepal. I don't know if in your context that you're working this is definitely the case, but often we don't also collect much sex and age disaggregated data. So where we just talk about children and deaths per 1,000 births, more broadly of children, infants, sorry, this is going to mask where there may be these kind of gendered differences and issues around feeding practices potentially. So just really highlighting why sex and age disaggregated data is so important. Okay, the third one is around around physical and sexual violence. I'm sure you're all aware of the issues around adolescent girls are much more likely to be exposed to different forms of gender-based violence, but certainly boys do also experience gender-based violence, and there's often very significant taboos around adolescent boys and men reporting, well, not just adolescent boys and men reporting on forms of violence, especially sexual violence, but also around physical violence, especially within the home, because there is this perception that men should be in control, they should be the ones that are dominant, and so therefore these kinds of violence, especially when the violence is used as a way of kind of emasculating men when used in the context of war, as a weapon of war, these kind of sexual violence is very much underreported in general anyway, but then added to that this extra stigma. And women and girls obviously face different forms of stigma actually around, especially if girls are unmarried, they may well be married to perpetrators. So there's many different barriers for those reporting gender-based violence. The fourth one is around, around this kind of perception of boys and men being providers and protectors. So there's this kind of, especially in conflict scenarios, very much increased recruitment of boys as child soldiers, or increased risk-taking behaviour, being involved in gangs or criminal activities, and boys being denied a voice to express their emotions. They're supposed to show very much a lot of strength, a lot of bravado. This impacts in terms of their mental health. Then finally, depends, but in several contexts, and certainly this is the case in Syria, that women and girls are significantly limited in their mobility, especially where there's high risks of sexual violence and other forms of violence, as a way of protecting girls as an assumption that this will protect women and girls. There is often a limitation in terms of mobility. This then impacts on their ability to access information, to be involved in decision making and things like this. But very much where there's a difference in decision making, women and girls often don't get to make as much decisions as they might do around accessing health services, making decisions on family planning, on how nutrition how to feed themselves and then also their children. And as we've mentioned before with the poverty statistic, there can also be preferential feeding practices. Okay, so how is it relevant in humanitarian context? How is gender relevant? As you can see here, from the photo below, so there's different roles that people play in a response. So you can see men, babies, and some women get across a river. So there can be like different expected roles around who does what in emergency to help. So yeah, especially this kind of provision of support. But women and girls, for example, they may be much more involved in water collection, in cooking, in things like this, and men and boys may be much more expected to be out earning an income for people, may be involved in a conflict and things like this. So based on our kind of gender roles, we're going to have different experiences in an emergency situation, be it in a conflict, be it in a flood, or any kind of a natural disaster. Okay, so we have some key risk factors that as humanitarian health and nutrition staff we would be considering in our response. So I would like us to talk a bit about what these might be. Whoops, sorry, went ahead too much. So these key risk factors are insufficient nutrition intake, overcrowding, inadequate shelter, insufficient vaccination coverage, poor water, sanitation and hygiene conditions, high exposure to disease vectors and lack of treatment, violence, HIV and mental health. So when we are trying to understand the context and understand how we're going to set up our response and what are the key issues and that in terms of health and nutrition that people are exposed to, we want to think about these different factors. So I'm wondering if you can put in the chat box any of the kind of gender related dynamics or issues that you would see happening with any of these different risk factors. Okay, yep, so we have some mothers in the context of malnutrition tend to prioritize boys when food is scarce. Any other thoughts related to any of these other risk factors? So some of them, so that's the insufficient nutrition intake, so that can definitely have a difference. Marriage age, yep. So that obviously has an impact relating to, relating to treatment, but it's actually an interesting one. It doesn't necessarily fit into the risk factors here. Gender-based violence, yeah. So gender-based violence relating to overcrowding, inadequate shelter, especially poor water, sanitation and hygiene conditions, violence in general. There's also issues around lack of treatment, so around the stigma related to gender-based violence, which means survivors might not come forward. Any other thoughts? I mentioned earlier around mental health, so there's different pressures on men, women, boys and girls depending on what their role is, and there's certainly around this either loss or difficulties to provide for your family especially, and the social kind of expectations around men and boys being strong prevents them necessarily from seeking support more generally for health related concerns, but it's mental health. Yeah, working men will get better quality food compared to women. Yep, but also I think there's often a lack of recognition, especially that of the role of women and girls. So we expect working men will get more food, but actually if pipe water, for example, to house is disrupted, they have to walk far to get water, doing a huge amount of household work. This is a significant amount of work which actually is often not really recognised and taken into account in terms of distribution of food within a household. Boys obliged to get involved with military actions, definitely involved in violence. And Hani is saying lack of access to health service for women in insecure locations. Well, actually, there's many different barriers that might affect kind of lack of treatment, but certainly decision making within the household. So one statistic I didn't share with you was also around men, mostly as the key decision makers relating to whether or not women and girls would access treatment. So these are kind of key issues that need to be considered. Yeah, so privacy is important in terms of accessing health services as well. And just to summarize quickly so that we can move on, there's often also a high exposure to disease vectors, and it's different depending on who you are. So for example, if women and girls are collecting water in unsafe conditions, standing around in these in water that's contaminated, that may expose them to that, to various different health issues. Also around who sleeps within the mosquito net, what are the sleeping conditions, whether you're on the floor or whether you're on a bed. And so often there's differences between men, women, boys and girls within the family about how you're treated, and therefore what kind of disease vectors you might be exposed to. The water sanitation and hygiene are especially related to gender-based violence, but also if there's not a lack of privacy, which I think some people are mentioning, and crowded conditions, there's often the issue of women and girls may actually reduce intake of water because they're concerned about being seen to go to the latrines, or about their safety issues around accessing those. Okay, right, I will move on, but this is something basically that when we're starting to analyse and assess a situation and how we respond, it's important to understand what those differences are, because without understanding the kind of gender dynamics and what people's roles are within the context, both how they were before the crisis and then what's happened in the crisis situation, we're going to be unable to address some of these issues which are affecting excess mobility and mortality and malnutrition rates. Okay, so what's our mandate as humanitarians? Well, there's several kind of key factors relating to this, but at the global level we have this transformative agenda where we're working on improving the effectiveness and efficiency of humanitarian assistance, and recently the core humanitarian standards have come out, which put communities and people affected by crisis at the centre. Something really here that if we don't recognise these gender differences, these age differences and other and people's social background, we're not actually going to be putting all people who are affected by crisis at the centre and ensure that they all access assistance that they need. We may even cause harm if we're not considering what those different needs are, and if we're not responding to them effectively. So to meet these core humanitarian standards, to meet our aims as humanitarians to provide impartial, independent assistance, we actually need to make sure that we are considering and identifying what the different needs of men, women, boys, girls are in a crisis, and what kind of barriers that they may face to accessing our assistance, so accessing our health and nutrition services. There's also, of course, related to this, we have a mandate to promote gender equality and promote and protect from violence. This is enshrined in various UN Security Council resolutions, but also in international and national law, and especially related to the Convention on the Rights of the Child, and also Convention on elimination of all forms of discrimination against women and girls. There's also, as you can see, the Interagency Standing Committee here, and these are some core guideline documents for us. And the Interagency Standing Committee has guidelines, has a policy on gender actually, promoting gender and protection as central to our work, and also there's guidelines on gender and gender-based violence and how different sectors should be responding to these. It's also, of course, and it's not on this diagram, but many different donors also require it, so ECHO, USAID, the UK government. It's key to the way we work, and actually we need to do something about it to make that a reality. So what are we going to do about that? Well, we need to first understand what success looks like. I know we're running out of time to some extent, but this is quite a crucial element of understanding where do we go from here. So as you can see from this diagram, we have an arrow going from gender exploitative to gender transformative. So gender exploitative is where we take advantage of rigid gender norms and power imbalances to achieve our program's objectives, but potentially this actually may create and, well, not just create, but it can reinforce gender inequalities and may lead to exploitation and harm for those involved. Gender unaware is where we're not recognising the differences between men, women, boys and girls, so we program and we assume, for example, that if we set up a primary healthcare unit or a mobile clinic, that everybody who needs help is actually going to be able to access that assistance. And we haven't identified what the different barriers might be for men, women, boys and girls, and we therefore haven't programmed them in. So while we have set up a service which should benefit everybody, it's unaware of whether or not it does actually have that benefit. So it may inadvertently reinforce inequalities. The minimum standard actually for the sector is that we are making sure our programs are gender sensitive. So this is understanding what those different needs are, understanding that people are different, they have different roles, exposures to risk, they have different capacities, and then programming for them. So sometimes that means, there's an element of integrating that across our program. Then if we're talking about gender transformative, this is where we're understanding and recognizing those differences, programming for them, but then we're also working very explicitly to promote gender equality and to change or transform the root causes of gender inequality. So how boys and girls are treated differently and how that creates power inequalities and differences in resources and opportunities. So often the gender transformative one is difficult in emergencies, but it's also it's not necessarily the case that it can't be done, because actually crisis does change gender roles, as in people are not necessarily the same thing that they were pre-crisis. They may be then taking up different activities outside the home. So often where there's a disruption of livelihoods, especially of men and boys, then women and girls may be required to be involved in different kind of livelihood activities. So there is these, or especially if men and boys are separated, and it often happens during displacement as a coping strategy, there's then different roles and activities that different members of the family might get involved with. So this is quite crucial to recognise and then address within our response, both from a gender sensitive point of view but also from a gender transformative. There is actually on this slide, and I'm not sure I'm going to go into it in significant detail because I think that you should go through it together, and I think we're running out of time. So there's some examples here. So this one is a case study, and you can go through that separately to decide whether or not it's gender sensitive, gender unaware, etc. So this PowerPoint presentation will be shared with you, so you can also look at that case study for yourself. But there's 4 different examples of projects here, and they relate to whether or not they're gender exploitative, unaware or sensitive, and there will be an explanation of the reasons why. It is an important point to make so that we understand whether or not, and we can identify whether or not our humanitarian health and nutrition programs are actually contributing to promoting gender equality. So actually, how are we going to do this? So how do we make sure our interventions are gender sensitive in health and nutrition? Well, as we mentioned at the beginning, it's very important that we recognise differences between people. So there's a little cartoon here of a goat and a crane. Well, we're recognising that they're different and one size does not fit all. So the plate that the goat eats out of is clearly different from the well, the plate or the implement that the crane is able to eat out of. So in this first top example, you can see the goat has invited his friend the crane over for dinner, but he can clearly eat much more than the crane can because of the shape of their beak, of the beak and the mouth. And then vice versa on the below picture, where the crane is much more able to eat food from the long jar and the goat is not. So if we provide one size, as in one kind of intervention, it's not necessarily going to mean that both are able to access that sufficiently. But we also need, this one doesn't also recognise that there may be systematic inequalities or differences between how the goat and the crane are treated, or how men, women, boys and girls are treated in society. And so sometimes we may need to do something very specific in order that well, targeted actions is what we call them, in order that we're actually able to address these inequalities. This is a very important slide from the Interagency Standing Committee Gender Handbook, which helps everybody to understand what they need to be doing in an emergency. Key is the basis, so that we conduct a gender analysis. We understand what the differences are between men, women, boys and girls of different ages and different social backgrounds, which then informs our planning. Then key strategies are gender mainstreaming, so integrating this across different sectors in our response, but then also making sure that we target actions based on these gender inequalities, so that we're addressing these differences, be it in the access to assistance for whoever is excluded or whoever has significant barriers to access a service. And then of course the goal is that we're promoting the human rights of men, women, boys and girls equally, and that they're also protected. You can also see various other different strategies here around addressing gender-based violence and sexual exploitation and abuse, as well as making sure there's a gender balance in humanitarian agencies. Thank you, Alice. Alice has also mentioned equity versus equality. Yeah, so I've actually just skipped through that a little bit, but it's an important note. So equality, as we saw at the beginning, was where there's an absence of discrimination on the basis of sex. Everybody is able to access resources equally, but that certainly isn't what's happening at the moment. But how do we achieve that? And where there is these differences in who access resources, who's given what, who has power to make those decisions, that's where we may need to have strategies which are equitable, which means around ensuring that we target actions so that, for example, well, one good example is with education, and then we can think about it for health and nutrition. But it's basically, okay, if there's more boys going to school than girls, then you would have a targeted campaign on ensuring that girls also go to school. So it's not detracting from the other. It shouldn't be around boys don't go to school so girls can. It's around making sure that actually girls do get a chance to go to school. There's many issues around whether or not then they can study as much as their brothers, so there would also need to be considerations around kind of fair distribution of the work in the domestic sphere, because often girls are much more involved in kind of collecting water and looking and cooking and things like this, which affects their sort of time that they have available for education. So in terms of health and nutrition, this would also be specific targeting where we need to, in order that we achieve equality. If we can think, often in health and nutrition there's this issue around decision making, so it would be looking at women and girls making decisions over family planning and things like this, and this doesn't happen overnight. Obviously there's a need, and one key thing in terms of gender equality is that we're not only focusing on women and girls, is that to achieve gender equality, men and boys need to be involved. They need to understand, everybody needs to understand that actually gender inequality affects all of us. It's not beneficial. It's something that actually, if we're looking at improving health outcomes, if women and girls are accessing health services late, it can increase morbidity and mortality. And if men and boys feel that they can't come because there's stigma attached to them coming or being involved, in those in services, then it also means that their health is affected as well. So it's around engaging everybody, and that's the transformative element of it, but also in an equitable way so that we're addressing these imbalances between who accesses services, who accesses resources, whose health is more affected in a crisis. Okay, so I have mentioned gender analysis, and we don't have a long period of time to it. In fact, we need to wrap up. But what's crucial to know is that we are understanding what the situation is both pre and post crisis, understand the different roles of men, women, boys and girls, understand what their needs are, understand their different capacities and what different barriers they might have. So it could be especially around differences in literacy levels or decision making power and things like this, why they exist, and then what the impact of that is on health and nutrition outcomes. There's also a slide down here about the importance of sex and also age disaggregated data, and why that's really important to be able to identify whether we are actually targeting and benefiting the people that we want to, or whether there could be an imbalance in those who access our services if we're not monitoring that. Yeah, through questionnaires or focus group discussions, exactly. So there are some questions that, in fact, there's an interagency standing committee guideline on gender, and that actually has a health and nutrition section, and it has some key questions that you should be asking for humanitarian health and nutrition that you can do in a rapid way, both through questionnaires and focus group discussions, and you can integrate into more in-depth sectoral assessments as well. Okay, if there's any, well, this is the domains of gender analysis. It's around understanding these roles and relationships, these norms and rules, so power and decision making and access to resources and services. So there is some of that in terms of the questions that we would ask. So in terms of questions, the kind of things that we would want to know for health and nutrition, for example, would be how has the health of the population changed since the crisis? How are women and men treated differently? What are the diseases and other health problems that they have? What's the difference in mortality rate between men, women, boys and girls, and why? Who provides the health care and by who? So for example, access to resources and services. If you have a lot of kind of men providing health services, you wouldn't be able to so many times, especially for example in the Syria context, there will be challenges for women and girls to access for that reason because of social barriers around talking with men about certain issues. So I have a quick break, 1 second. Okay, sorry about that. Then also, are there kind of any, so norms and rules, are there any local beliefs or practices around healthcare? Is there specialised medical care included in maternity hospitals? Yeah, those can be questions. But the kind of things that we're looking at are kind of what are the reasons why people wouldn't be able to access services, or what are the differences, different kind of risk factors that they might be exposed to for health and nutrition. So some of the things can be around local beliefs and practices on pregnancy and birth and family planning, disposal of dead bodies, washing, water use, cooking, animal care. So many of these there's differences between who does that in an emergency context, and therefore what kind of disease vectors they're exposed to, what kind of risk factors there are. And also, especially related to access, there's very often significant differences around information to health services because of where the information is presented. So is it given in through a mosque, for example, or is it in a community meeting, which often men and boys are much more kind of involved with, and especially where there's restricted mobility for women and girls, like is it house to house, who's delivering that message, is it a man or a woman, things like this. These can also affect people's access to information and service provision. For nutrition, again, there can be this, you know, we need to look at the differences in nutritional status. So where if we just say children, it may mask these differences between boys and girls of different age groups. We may want to then also understand why they're affected differently. And then what are the connections between gender and social position in terms of malnutrition rates. And then cultural practices and beliefs around nutritional status of men, women, boys and girls, and how that might be affected differently. Also, who prepares food, who makes decisions on food expenditure, who makes decisions on distribution of food within the household. So we talked a little bit earlier about often men, especially working men, may be given the larger proportion of the food and the more nutritious food, especially where resources are scarce. But men and boys often don't have the skills to cook in many situations, and therefore if they're also not with their families or with people who are cooking for them, there can be significant issues around malnutrition depending on the context. So this is it's important to understand those differences and then program for them. So how do we basically design programs and monitor that we are actually having this impact, that we're actually creating gender sensitive programs at a minimum? Well, one of the key things is, first of all, please use the Interagency Standing Committee Gender Manual and also the Interagency Standing Committee GBV guidelines, because they have different sections on health and nutrition within them and what we would be expecting to see in a response. And these are our kind of industry standards. But there's also an Interagency Standing Committee Gender and Age gender equality measures and gender and age marker. So the gender equality measures is overall across the kind of programming cycle, and the gender equality marker is for the proposal design stage. So I'm just going to quickly go into it because this relates to the assignment that you have after this. So basically how we use this marker is, first of all, you just really need to get familiar with what the guidance is around gender and GBV in humanitarian contexts for health and nutrition. Read the gender marker instructions clearly, but basically you go through and you score your proposal based on whether in your needs assessment, in your activities, in your log frame, and in your budgets you are considering gender, and then you score your proposal and find out what it means and then take action. So what does this actually look like? So in terms of the needs assessment, what needs to be in there is especially the gender analysis. So we need to understand what the different needs of men, women, boys and girls are, what their roles are, what the dynamics are, any barriers to accessing health and nutrition services in the context. And that needs to be clearly within our needs analysis of the situation. When we're also implementing, we need to see this gender analysis. So it's not a one-off necessarily. It certainly should be there in the assessment phase, initial assessment phase, in order to design the program. But then we would also want to see that being monitored. Are there any differential impacts of the implementation of and provision of our health and nutrition services? We should be collecting and analysing sex and age segregated data, and we should be making sure our targeting is going well, especially that those who we intend to support are actually those who we are supporting or assisting. Then we want to see in the activities that we tailor these activities on the basis of this needs assessment, on the basis of understanding what the differences are between men, women, boys and girls, and act accordingly. So for example, if we see that decision making of women to access the health services is significantly affected by men and that women's mobility is restricted in a context, we certainly need to be having interventions where we are engaging men as those decision makers and women in why it's important to access this assistance, making decisions around family planning together. For example, if we're thinking about nutrition, we should be also considering you know, how decisions get made in the household and engaging men and boys in that as well. And often, especially, access to services is in agreement with husbands. So it's around making sure that there's a clear understanding of why and how this assistance will benefit, but also it's about thinking of who's providing those services. So are we unintentionally creating a barrier by having mostly men involved in the service delivery of health services, for example, and therefore women and girls don't feel as comfortable to come, or vice versa, certainly. We should also be considering around protection from gender-based violence, so understanding what the risks of gender-based violence are in the context that we should be responding to as health and nutrition experts, but then also around how in the provision of our assistance we don't unintentionally cause harm, cause gender-based violence or sexual exploitation and abuse, and then make sure that we're also coordinating with the gender analysis, sex and age disaggregated data. Third point is around adequate participation. So especially, we might say participation, okay, but who is actually participating and making decisions on our program? Often when we work through community committees, as we said before, men and boys tend to have the kind of space which is outside the home decision-making role. So are we reinforcing this decision-making role of men, or how do we have specific strategies or equitable strategies in order that women and girls are also part of the solution in terms of designing and delivering services? Also that people feel that there's feedback and complaints that they can give, and that we're also, in terms of transparency, communicating with different communities. We identify the differences in terms of access to information, and we're specifically making sure that we're actually addressing those. So for example, if women and girls don't go to certain places or have low literacy levels, we don't only just write information or provide information at community meetings, but we may need to do house-to-house visits. But also in terms of participation, really key strategy is around having separate spaces for women and girls, which are safe, which are, and are also part of engaging men and boys as well, so that it's not sort of creating tension or conflict within the household or within the community. The final one is around monitoring and evaluation, really, setting targets. Why have we set these targets? Making sure our indicators are addressing or monitoring some of these kind of gender-related issues, and also making sure, crucially, that we collect user satisfaction feedback from, and we analyse the differences between men, women, boys and girls. We make sure we outreach and talk to them. We make sure that the benefits of our programme are equitably benefiting men, women, boys, girls, and we're addressing any project problems as they come up, especially related to any protection issues. The way that we score this is so using this Interagency Standing Committee gender marker, which I'll send to you, within the proposal, and we might get a 1, but it's still possibly not going to contribute to gender equality, so it'd still be gender unaware. But the score of 2, where we are actually identifying and addressing those needs coherently, and it's throughout the proposal, from the needs assessment activities, the log frame, the budget, that's when we can say that actually we're contributing to gender equality and our programme is gender sensitive. So if we see that we're getting a score of 0 or 1, we're going to actually need to look back towards the Interagency Standing Committee guidelines, but also to see about working with a gender TA or working with an organisation that's doing work on gender and seeing, okay, what actually do we need to do to address this in the context. And one of the challenges with this is it does absolutely need to be context specific. A one size doesn't fit all, both for men, women, boys and girls, but also certainly not across different contexts. And that is the basis of making sure we're gender sensitive. There's links here obviously to these guidelines, so these are the Interagency Standing Committee guidelines that I've been referencing. They're on the internet. There's also the Interagency Standing Committee gender marker tip sheets, which I'll also share with you on health and nutrition. They're only a couple of pages, so they're also very helpful. But for the assessment side of things, these also have some good questions in it, especially the gender handbook. It has some really helpful guidelines on that as well. So yes, to come back to expected learning outcomes, but really the key to this is that actually we're not going to be achieving our humanitarian health and nutrition outcomes if we're not considering gender. We're not going to be effective and efficient in the way that we want to be in providing the quality of programming and care that we expect, and we potentially cause harm by excluding certain people from benefiting from services or not responding to the key issues that are happening in affected communities. Yeah, so if anyone has any questions, otherwise I will wrap up. No, maybe over to Alice in terms of what the next steps are.
Okay. Great, thank you so much, Catherine. That was really interesting, and thanks everyone for listening. If you do have any questions, then feel free to type them in the chat box while I'm just wrapping up. And of course, we have our discussion forum as well. So if anything occurs to you later, then feel free to post on there as well. So yeah, I hope that this session has given you all a bit of food for thought, and maybe it was going over some old ground for some of you, but I'm sure that there was some new and useful information for everyone in that. And we hope that you'll consider gender throughout all of the sessions in this diploma, and this is one of the reasons why we wanted this to be our first session of the diploma, so that it's something that underpins everything else that we're doing throughout the health nutrition diploma. So Catherine referenced an assignment that we'd like you to do as a follow-on activity from this session, and that's just to really kind of cement some of the learning. So what we'll do is we'll provide a bit more information on that, and we'll make sure that we send you the links to all of the resources that you'll need to do that. So we'll send that via email, and we'll also put that on the LMS. But the purpose of that exercise really is for you to practice looking at your programs through a gender lens. Okay. And yes, actually, Bashir, that was my next point. I was going to say, in an amazing coincidence, it is actually International Women's Day today, which we didn't actually realise when we were planning this this webinar. But I'd also like to wish all of you a very happy International Women's Day. And Hala, I've just seen you've asked a question, what proposal we have to submit. I think that's, sorry, we're not asking you to submit a proposal, we're just asking you to have a look at a proposal you might have worked on in the past, using some of these tools, so like the gender marker that Catherine mentioned, and perhaps reflect on whether or not you think that proposal takes gender into account as much as it could. Okay, so if there's no other questions, I'll wrap up now because I know we've gone a little bit over time, and thanks all of you for your patience. We have our next session running next Wednesday at the same time, and that is our introduction to nutrition in emergencies. So we're all really looking forward to that and hope you can make it. If you have any follow-up questions to this session, do let us know. Okay, thank you everyone.